Over the course of my career, I have performed surgery on more than 2,000 patients. I have held a living beating heart in my hands. I have felt the difference between a heart that is strong and one that is silently losing ground. For a long time, I assumed the worst damage I saw on that operating table came from the usual suspects: poor diet, smoking, family history. But some of the most severe damage I encountered had a different source entirely. It came from medications, pills that were prescribed with genuine care and good intentions, that were quietly working against the very organ they were supposed to protect. My name is Dr. Shoaib. I am a cardiovascular surgeon. I have spent 25 years operating on hearts that had reached the point where surgery was the last remaining option. Today I want to talk about 5 specific medications that millions of Americans over 60 take every single day, and a set of consequences that almost never comes up in a standard 7-minute appointment. This is not about alarming you. It is about giving you enough information to walk into your next doctor visit and have a more complete conversation. After 60, your body handles medications very differently than it did before. Your kidneys filter more slowly. Your liver breaks down drugs at a reduced pace. The average American over 65 is taking 4 to 5 prescription medications at the same time. Some are taking 8 or more. Each of those drugs was studied individually, approved individually, and prescribed individually. But almost no one is asking what happens when you combine 3 or 4 of them inside a body that is already working harder than it used to. That question rarely gets a real answer in a standard appointment. I want to tell you about a patient. I will call him Walter. He was 74 years old, a retired electrician, sharp and careful about his health. He walked 2 miles every morning without fail. He watched what he ate. He had every reason to believe his health was under control. Walter came to me following his second cardiac event in under 2 years. He was not just tired, he was exhausted in a way that sleep did not fix. Muscle cramps were waking him up at 3 in the morning. His ability to think clearly had slowed in ways that genuinely frightened him. He had seen 3 different doctors. Each one told him the same thing. "Walter, you are 74. This is what getting older feels like." He accepted that answer for 2 years. When I sat down and went through his complete medication list, every drug, every dose, every combination, I identified the problem in under 5 minutes. And it was not one problem. It was 3 separate problems happening simultaneously for 2 full years. I will come back to Walter, because the way his story ends is the entire reason I am making this video. Now the 5 medications. The first is statins. If you are over 65 in America, there is roughly a 1 in 3 chance you are taking one right now. The names vary, but the mechanism is the same. Statins save lives. For people with established heart disease, the evidence supporting them is solid and consistent. I have prescribed them thousands of times and I stand behind that. But there is a consequence buried in the fine print that most patients are never told about. Statins work by blocking a specific biochemical pathway in the body. That pathway does not only produce cholesterol, it also produces something called CoQ10 or coenzyme Q10. And that distinction changes everything. CoQ10 is the primary fuel source for your heart cells. Think of it the way you would think of engine oil in a car. Without enough of it, the engine runs rough and gradually wears itself down. A major analysis published in 2005 and replicated multiple times since then demonstrated that statins reduce CoQ10 levels in the blood by 30 to 50%. That is a 30 to 50% depletion in the very substance the heart depends on most. In real patients, that shows up as persistent fatigue that rest does not relieve, muscle weakness, mental fog, and measurable reductions in cardiac function in a meaningful subset of people taking these drugs. Walter had been on a high-dose statin for 2 full years, 2 years of his heart running below its functional capacity. And here is the part that should give you pause. CoQ10 testing is not part of standard clinical guidelines. Many insurance providers will not even cover it. CoQ10 itself is available over the counter. There is no patent on it. There is no profit margin tied to it. There is no financial incentive for anyone in the system to push for its inclusion in the standard protocol. I am not suggesting that is by design. I am saying it is a system with no mechanism to ask an inconvenient question. The practical consideration is 100 to 200 milligrams of CoQ10 daily. A major clinical trial showed measurable improvement in heart failure patients who supplemented it. The question worth writing down before your next appointment is simply this. Given that I am on a statin, Should I also be taking CoQ10? Not should I stop the statin. Just that. The second medication surprises most people because it does not look like a heart drug at all. That is precisely why it is so often overlooked. Ibuprofen, naproxen, diclofenac, the non-steroidal anti-inflammatory drugs available over the counter, inexpensive and sitting in nearly every medicine cabinet in the country. Most people assume that because these drugs reduce inflammation, and inflammation is hard on the heart, they must be neutral or even beneficial from a cardiovascular standpoint. That reasoning is exactly backwards. These drugs block specific enzymes in the body. One of those enzymes produces a compound that serves as a natural protector for your blood vessel walls. It keeps vessels flexible and prevents dangerous clotting. Block that production and you remove that layer of protection. At the same time, regular use of these drugs raises blood pressure by an average of 3 to 5 points. That sounds modest, but in someone over 60 whose arterial walls are already less flexible than they once were, that sustained increase compounds over time into a meaningfully elevated risk of stroke and cardiac events. The FDA placed its strongest available warning label on this entire drug class in 2015, not only for the well-known risk of stomach bleeding, but specifically for heart attack and stroke. That warning is on the label right now. Walter had been taking ibuprofen every single day for 2 years for joint pain. His doctor was aware. No one raised the cardiac concern. For people dealing with chronic joint pain, topical anti-inflammatory gels deliver the same localized effect with approximately 90% less systemic absorption. For chronic background inflammation, curcumin combined with piperine has meaningful clinical support, as does 2 to 3 grams of omega-3 fatty acids daily. A landmark clinical trial showed a 25% reduction in major cardiovascular events with high-dose omega-3 supplementation. That is a number worth knowing. Do not stop a prescribed anti-inflammatory without your doctor involved. The goal is a better conversation, not self-treatment. The third medication is the one that took the medical community an embarrassingly long time to connect to heart health, because it looks nothing like a cardiac drug. People purchase it without a prescription, take it with their morning coffee, and never think twice about it. Proton pump inhibitors, omeprazole, pantoprazole, lansoprazole, roughly 15% of the entire adult population in America takes one of these. Many have been taking them for years, some for decades. Here is what does not make it into most conversations. Your stomach acid is not something to be eliminated. It is a gatekeeper. You need it to absorb vitamin B12. Suppress that acid long-term and you suppress B12 absorption almost entirely. Why does a heart surgeon care about B12? Because it is essential for breaking down homocysteine, an amino acid that when it accumulates in the blood causes direct damage to arterial walls. Elevated homocysteine is an independent risk factor for cardiovascular events, comparable in some studies to elevated cholesterol, and almost completely absent from standard cardiac workups. A study published in a major gastroenterology journal found that long-term users of these drugs had B12 levels 30% lower than non-users, in a population already experiencing declining B12 absorption as a natural consequence of aging. After 60, your stomach produces less of the protein needed to absorb B12 on its own. A drug-induced deficit layered on top of an age-related one creates a compounding problem. B12 deficiency presents as fatigue, memory difficulties, and a gradual tingling in the hands and feet that develops so slowly you may barely register it at first. In severe, prolonged cases, the neurological damage is irreversible. From a heartburn pill taken for 10 years because no one checked levels annually, these drugs also deplete magnesium, which is involved in more than 300 enzymatic processes in the human body. For the heart specifically, magnesium regulates the electrical signals that keep your heartbeat steady and consistent. A deficiency is directly linked to arrhythmia and to the kind of muscle cramps that wake you up in the middle of the night. Walter's B12 came back critically low when we finally tested it. The fourth medication is one of the oldest and most widely used blood thinners in medicine. Warfarin. Millions of Americans over 60 take it for atrial fibrillation or to prevent stroke. It works by blocking vitamin K, specifically to reduce the blood's ability to form dangerous clots. But vitamin K is not a single compound. There are two primary forms, vitamin K1, involved in blood clotting, and vitamin K2, which plays a completely separate and critically important role. Vitamin K2 activates a protein in the body whose specific function is to prevent calcium from accumulating in arterial walls and direct it toward bone instead. Without adequate K2 activity, calcium does not stay where it belongs. It migrates, it settles into vessel walls. Over time, the arteries become rigid and calcified, like pipes slowly filling with mineral deposits. Warfarin blocks K2 just as it blocks K1. So while it is preventing dangerous clotting, it is simultaneously removing the body's primary defense against arterial calcification. A study published in a major cardiology journal found that long-term warfarin users showed significantly accelerated coronary artery calcification compared to similar patients on newer anticoagulant medications, in patients whose physicians were actively working to protect their cardiovascular health. As a surgeon, I have seen what heavily calcified coronary arteries look like on the operating table. The calcification makes the procedure harder, the recovery longer, and the long-term outcome more uncertain. This does not mean anyone on warfarin should stop taking it. Untreated atrial fibrillation carries approximately a 5% annual stroke risk. That is not something to dismiss, but it does mean asking two specific questions at your next appointment. First, are there newer anticoagulant options that might be more appropriate for my situation? Several newer medications do not carry the same interference with vitamin K2. Second, has anyone ever measured my coronary artery calcium score? A low-radiation CT scan provides a precise picture of what is currently happening inside your arteries. It is one of the most underutilized cardiac risk assessment tools available, and a single scan can meaningfully change treatment decisions. The fifth medication is the hardest one for me to discuss. Not because the science is difficult to understand, but because I recommended this one myself for years to patients who placed their trust in me. I gave that recommendation confidently and completely, and I was wrong. Calcium supplements. If you are a woman over 60, at least one physician has almost certainly told you to take calcium for your bones. The dosage is routine. It barely registers as a serious medical recommendation. It feels like obvious common sense. In 2010, a major meta-analysis published in a leading medical journal examined 15 randomized controlled trials involving nearly 12,000 patients. Calcium supplementation, without the accompanying nutrients K2 and D3, was associated with a 30% increase in cardiovascular event risk. 30%. A room full of women faithfully taking their calcium supplement every morning because their doctor recommended it, and roughly 30 of them may be meaningfully raising their cardiac risk while believing they are doing something protective. The mechanism is known as the calcium paradox. Supplemental calcium taken without K2 and D3 enters the bloodstream as a sudden concentrated surge. The body cannot direct all of it appropriately at once, and one place it ends up depositing is arterial walls. The same calcification process we just discussed with warfarin, but driven this time by the supplement itself. You take a pill to protect your bones. It hardens your arteries instead. Why have clinical guidelines not fully caught up to this data? Reversing a recommendation that was given to tens of millions of patients over 20 years is institutionally complicated. There are liability concerns. There are industries built around calcium supplement sales. It is easier to add a quiet footnote to existing guidance than to say plainly that the original recommendation was incomplete. For the first 15 years of my practice, I recommended calcium to older female patients as a matter of routine. A 68-year-old woman with early bone density loss, calcium and vitamin D, 1,200 milligrams daily. Take it with food, every time. I was doing exactly what I had been trained to do. When I sat with that research data and really absorbed what it was saying, I thought about every patient I had given that recommendation to. Every woman who had been taking that supplement faithfully every morning. I felt a sense of responsibility. Not guilt for what I could not have known, but responsibility to make sure the next patient gets the complete information. That is why this conversation matters. If you are currently taking calcium supplements, do not stop suddenly, particularly if you have a documented diagnosis of bone density loss. But bring this question to your physician at your next visit. Given the evidence, should I be taking K2 and D3 alongside my calcium? For most patients, the answer supported by current research is yes. Vitamin K2 in the MK7 form at around 100 micrograms daily, and vitamin D3 at a minimum of 2000 IU, with adjustments based on your blood levels. And wherever possible, prioritize dietary sources of calcium first. Dairy, leafy greens, small fish eaten with the bones, Use supplements to fill actual gaps, not as the primary source. I have spent most of this video on what these medications take away from the body. Let me spend a few minutes on what genuine heart protection actually looks like after 60, because most of it is straightforward and does not require a prescription. Omega-3 fatty acids at 2 to 3 grams of EPA and DHA daily reduce triglycerides, lower systemic inflammation, and help maintain vessel wall flexibility. Chelated magnesium at around 400 milligrams daily supports heart rhythm, blood pressure, and sleep quality. After 60, dietary intake tends to drop, while the body's demand stays the same. Curcumin combined with piperine has genuine evidence behind it for the kind of chronic low-grade cardiovascular inflammation that quietly drives long-term risk. Nattokinase shows real promise for healthy blood flow and reducing excess fibrin that contributes to clot formation. Taurine supports cardiac muscle function. Aged garlic extract has meaningful published data behind it for blood pressure and arterial flexibility. Both have long safety records. None of these are miracle solutions. None of them replace medication where medication is clinically necessary. But they represent what the body needs to function well, and what consistently gets crowded out when no one is keeping track of the full picture. Here is the one practical step I want you to take before your next appointment. Write down every medication and every supplement you take, with the dose. Then write 3 words at the top of that list. What am I losing? Every drug involves a trade-off. Statins lower cholesterol and deplete CoQ10. Proton pump inhibitors suppress acid and block B12 and magnesium. Warfarin prevents dangerous clots and accelerates arterial calcification. Calcium supplements protect bone density and, without the right cofactors, may harden arteries. None of those trade-offs automatically mean the medication is wrong for you. They mean the conversation is not complete without them, and you deserve the complete conversation. Let me come back to Walter. After reviewing his full medication list, I sat with him for 40 minutes. Not 7, 40. We went through every drug, every dose, and every interaction. Then I reached out directly to his cardiologist and his primary care physician. Together we built a coordinated plan. CoQ10 at 200 milligrams daily. His B12 came back critically low, so sublingual methylcobalamin was started immediately. Chelated magnesium was added. His daily ibuprofen was switched to a topical diclofenac gel. Same anti-inflammatory benefit delivered locally with 90% less systemic exposure. His primary care doctor began a gradual taper of his proton pump inhibitor. Vitamin K2 and D3 were added alongside his existing calcium. Nothing dramatic, no new surgery, no breakthrough drug. We simply stopped depleting the things his heart needed to function properly and began replacing them. That is all. 6 months later, Walter called me. He said that for the first time in 2 years, he felt like himself again. The exhaustion was gone. The 3 in the morning cramps had stopped within the first month. His cardiac follow-up showed measurable improvement in heart function. His primary care physician called me, genuinely puzzled by the results. The improvement did not fit the expected trajectory. Nothing had changed except that the full picture was finally being addressed. That is what continues to strike me most after 25 years. Not the complexity of what had gone wrong, the simplicity of what helped, a few targeted supplements, a single medication swap, and a 40-minute conversation that 3 previous appointments had never made room for. The medications on this list are not the enemy. The physicians who prescribe them are not being careless. The problem is a system that is built around the act of prescribing, with no reliable mechanism to reward the follow-up. No built-in time to ask what this combination is quietly doing to this specific patient over the next 2 years. You cannot change that system today. But you can walk into your next appointment with a complete list and 3 words written at the top. And sometimes that is enough. If this video was useful to you, please share it with someone you know who is managing multiple medications. A parent, a spouse, a close friend who has been told that their fatigue is simply part of getting older. It may not be. Everything I have discussed here is grounded in published clinical research and my direct experience as a cardiovascular surgeon. Your situation is individual. Bring these questions to your own physician before making any changes. This is meant to be the beginning of a more complete conversation, not a replacement for one. Take care of your heart. It has been doing its job every second of your life without ever stopping to ask for anything in return. The least we can do is pay attention.